closer look at the individual injectable local anesthetic agents. The three you see listed here are classified chemically as amides, and you'll notice the first one is Novocaine, the one that everybody calls local anesthesia. It was the first developed local anesthetic injectable agent. It's no longer in use today and hasn't been for quite some time, because the drugs we have today are far better in terms of allergic response and their duration of action. The one that's most noteworthy is Tetracaine, because although it's not used as an injectable anesthetic, it is still in use as a topical agent, and it's very potent. So we have to be cautious if we administer it to anybody who has a documented allergy to ester-based anesthetics. And even if they don't and we use it, we have to remember that because of its potency, when you apply it topically, some of the drug is absorbed into the bloodstream, and as such we have to factor it in the amount of local anesthetic that a patient might be receiving. The amide drugs I call the I drugs because you'll notice although they all end in cane, there is an I in the beginning part of each of the generic names: lidocaine, mepivacaine, prilocaine, articaine, bupivacaine, attidacaine, and ropivacaine. It's important to remember that amide drugs have a longer duration, primarily because they produce less vasodilation. They're metabolized in the liver, so we have to use them cautiously in patients who have any form of liver dysfunction. And they're classified according to the duration of action: short, intermediate, or long. The short duration amide anesthetics are 2% lidocaine, 4% prilocaine, and 3% mepivacaine, all giving us pulpal anesthesia of about 30 minutes, and you'll notice that at these concentrations none of them contain a vasoconstrictor. Those same drugs, and a fourth one, Octocaine, when combined with a vasoconstrictor, give us intermediate duration or pulpal anesthesia of about 60 minutes. Long duration or pulpal anesthesia of 90 minutes. The two agents are bupivacaine and attidacaine, which until a short while ago was available in the United States. Let's take a closer look at each of the individual agents. You should be very familiar with the drug called lidocaine. I've listed here two of its more common trade names. It's the amide that's been around the longest, and so other amide agents are compared to it. The toxic reactions seen with an overdose of lidocaine often proceed right to symptoms of central nervous system depression. What this means is that most of the time when an amide is put into the bloodstream at too rapid a rate, or too much is absorbed, or too much is given, the symptoms of that oftentimes manifest as stimulation. The patient becomes restless, anxious, agitated, and may go into a convulsion. When an overdose of lidocaine is received by a patient, a lot of times you won't see that stimulation. They will just go into signs of depression. We'll talk more about local anesthetic toxicity at a later point. Allergic responses to lidocaine are very rare, and some literature says that there have been no true documented allergies to pure lidocaine, that all of the allergic responses have been to some other agent that's added to the local anesthetic. Lidocaine is available in several different formats without a vasoconstrictor, but the duration is very short and you don't see too many people using it in this 2% concentration with no vasoconstrictor. It's also available with epinephrine in ratios of 1 to 50,000 and 1 to 100,000. When it's used with the 1 to 50,000 ratio, it is primarily used for hemostasis or to reduce or control bleeding. The most common formulation is 2% lidocaine with a vasoconstrictor of 1 to 100,000 epinephrine. It's considered to be the drug of choice if you have to use a local anesthetic during pregnancy. It's also effective both as an injectable agent and as a topical agent, but when we use it as a topical agent, we must recognize that the concentration we're applying is higher than 2%, normally 5%. Mepivacaine, which its most common trade name is carbocaine, has a very similar onset potency and toxicity when compared to lidocaine. Its major advantage is that it does have a slightly longer duration due to the fact that it produces somewhat less vasodilation. And in that regard, it is available in two different concentrations. A 3% concentration where there is no vasoconstrictor added to it. Many practitioners select this when a vasoconstrictor is contraindicated or not needed. And it was until a short time ago available in a 2% concentration with a vasoconstrictor called levonorepinephrine. It is not available in the United States at this time at that concentration because the vasoconstrictor levonorepinephrine is not available, which I'll explain later on. Prilocaine carries two trade names, Citinest and Citinest Forte. Citinest, some people call prilocaine plain. That means there's no vasoconstrictor added. And when the vasoconstrictor is available, it is called Citinest Forte. Although it's an amide, it has a slightly different chemical structure, and this different chemical structure is what gives it the longer duration. That is what makes it available to produce pretty adequate anesthesia without the vasoconstrictor. So you'll see here it's available with a 4% concentration, epinephrine 1 to 200,000, or 4% concentration with no vasoconstrictor. The most noteworthy thing about prilocaine is that it does carry some relative contraindications. The relative contraindication is normally any condition where the oxygen carrying capacity of the blood is reduced in some way. These are conditions like anemias, sickle cell anemia, a condition called methemoglobinemia, or when the patient has hypoxia due to a cardiac or a respiratory issue. It's also a relative contraindication in patients taking daily and higher doses of Tylenol or acetaminophen. Probably the most important thing to remember about prilocaine is its association with the condition of methemoglobinemia. Methemoglobinemia is a cyanosis-like state that can be due either to a congenital metabolic error or disorder, or sometimes it's caused when people are exposed to certain chemicals or drugs. Prilocaine is one of those drugs that can kick off the condition of methemoglobinemia if a person has a subclinical case of it. So what you want to remember is prilocaine can induce methemoglobinemia in patients that have never experienced it before. The primary sign would be that they develop cyanosis. Octocaine is a relatively newly introduced injectable local anesthetic in the United States, although it's been used in European countries for quite some time. It didn't get approved by the FDA for use in the U.S. until 2000. It is an amide, but its chemical structure is slightly different in that it contains an amide grouping and an ester grouping. And the importance here is that its biotransformation, or its metabolism, takes two phases. Part of it is metabolized by esterases in the blood, and the other part of it is metabolized by enzymes in the liver. I know a number of dentists who really like Octocaine because they feel that they are able to get successful anesthesia simply by using infiltration on the mandible, although there is no scientific literature to support that. Probably the most important scientific literature to keep in mind is that the use of Octocaine is documented to cause more frequent cases of paresthesia, particularly when it's given with an inferior alveolar block on the mandible. You'll see here it says association with methemoglobinemia ? It's probably noteworthy to take note of the fact that these cases of methemoglobinemia have only been noted after the drug was given intravenously for regional anesthesia. That would be during surgery in a hospital. There have been no documented cases of that being produced when it was used in dentistry in its usual manner or at its usual dosage. Bupivacaine or Marcaine is not a drug that we normally use in clinical hygiene because it has an extremely long duration of action and we don't need for our patients to be numb that long. It is more potent than lidocaine but less toxic, and it is most commonly used in oral surgical practices when there are lengthy procedures that are going to take place, or it's given to the patient at the end of the procedure to help them deal with postoperative pain. You should remember that bupivacaine, because of its long duration, is contraindicated for use in children or anybody who might be prone to self-mutilation. It is available in a 0.5% concentration with 1 to 200,000 epinephrine. Attidicaine, very, very similar to bupivacaine. It has a slightly more rapid onset of action, but a similar long duration of action. It was removed from the United States market in 2002. I don't really know why. And the last one you see listed here is not yet used in dentistry. It has the longest duration of action of any injectable local anesthetic. It's used primarily in medicine for the management of postoperative pain. So how do we go about selecting the local anesthetic drug that we're going to use? Well, first of all, we have to ask ourselves, how long do we need the patient anesthetized for? Will the patient be needing any pain control after the treatment? Is there any risk of self-mutilation, so that we don't want the patient too long after we're done with our procedures? Do we need to reduce or control bleeding in any way? And what's the patient's physical status? Is there anything in the patient's medical history that would produce an absolute or relative contraindication for the use of the drug that we're selected? What does the word contraindications mean? Well, these are conditions or situations where we have to use caution. We either have to limit the amount of drug that we give, or we shouldn't give the drug at all. And that's the difference between relative and absolute contraindication. A relative contraindication means it's preferable to avoid using the drug, if at all possible, in order to reduce the risk of any adverse effects or complications. And if we do have to use the drug, then we should use the minimum dose that we need to control the pain if there is no alternative. An absolute contraindication means under no circumstances should the drug be administered. An example of this is if the patient has a true documented allergy to the local anesthetic or anything in it, then we should not use it. So what's in our local anesthetic cartridge? Well, there's the local anesthetic drug. There may be a vasoconstrictor, but as you know, they're not available in all local anesthetics. Excuse me. If there is a vasoconstrictor, then the local anesthetic will also contain a preservative or an antioxidant, which will increase the shelf life. In many instances, that preservative or antioxidant will be the chemical called sodium bisulfite, which I mentioned before. We have to use with caution in people who have allergies, particularly in people who have steroid-dependent allergic asthma. Sodium chloride is put into local anesthetics to make the solution isotonic with the body. That means that the local anesthetic has a concentration of solute particles that are the same as what exists in the body, so that the local anesthetic will exert the same amount of osmotic pressure. That helps the drug flow with the concentration gradient of the body. The drug is dissolved in either distilled or sterilized water, and the most important thing to remember is the amount of local anesthetic in each cartridge is 1.8 milliliters. This is what I already mentioned, that there are antioxidants, sodium chloride, and distilled water. Let's take a look at the vasoconstrictor drug that's put into our local anesthetic. It's put there in order to make the anesthetic safer to administer to the patient and also to increase the duration. It's important to remember that the vasoconstrictor does nothing to help the mechanism of action. It does not aid in the drug's blocking of that wave of depolarization. It simply makes the drug last longer and makes it safer to give to the patient. It's used in very dilute concentrations, which we'll take a look at in a moment. It's also important to know that when there's a vasoconstrictor in your local anesthetic, this decreases the pH of the drug itself. When we have a decreased pH of the drug and we give it, it delays the onset. It doesn't delay the amount of drug that will eventually be absorbed. It just means it takes longer for the drug to start to work. Also, the lower pH in many patients will produce a localized stinging sensation, especially if we administer the drug too quickly. You remember that all local anesthetics, with the exception of the drug called cocaine, make blood vessels get bigger. And when blood vessels get bigger, that means that the drug will be carried into the bloodstream more quickly, increasing the chance of toxicity and making the drug last less long, or decreasing its duration. The vasoconstrictors that are put in our local anesthetics are very similar in a chemical structure to the transmitters that are used by the sympathetic autonomic nervous system. So any drug that is similar to the action of those neurotransmitters is pharmacologically called a sympathomimetic or an adrenergic drug. So why do we put the vasoconstrictors in the local anesthetic? Well, by causing vasoconstriction or making the blood vessels get small, you decrease the blood flow of the place where you put the injection. By decreasing the blood flow and making those vessels smaller, you slow the absorption into the cardiovascular system. That puts less anesthetic into the bloodstream at one time and thereby decreases the risk of the toxicity from the drug. It also means you get less bleeding at your procedure site, which is, as you know, very handy when you're scaling and there's inflammation. The last thing it does is, as I've mentioned before, increase the duration and depth that we get from the anesthetic itself. It's important to know a little bit about the chemical structure of our vasoconstrictors. When there's a hydroxyl radical on an aromatic ring, the chemical is known as a catechol. If you add an amine group and you put the two together, it's called a catecholamine. If you have no hydroxyl radical but just the amine group, it's called a non-catecholamine. What you see listed here are chemicals that are listed as catecholamines and non-catecholamines. Some of the names may be familiar to you. Epinephrine and norepinephrine are the two neurotransmitters that are used by the body to transmit signals via the sympathetic autonomic nervous system. And as such, if we go into the lab and create a chemical that is identical to the structure of our body's own epinephrine or norepinephrine, then those chemicals are capable of attaching themselves to the same receiver or receptor that's used by our body's own norepinephrine or epinephrine, and therefore capable of transmitting the same information. It's important for you to recognize that the drug epinephrine that we put into our local anesthetic is chemically classified as a catecholamine. A little bit more physiology here. Our body has what are called adrenergic receptors, and these are little protein molecules that are located on the outside or the inside of many of our tissues and organs. The job of these receptors is to receive messages from chemicals released by sympathetic nerves. There are two different kinds of receptors that receive messages from neurotransmitters of the sympathetic system, and they're called alpha and beta. Alpha receptors are located primarily in the smooth muscle walls of blood vessels, in our skin and in our mucous membranes. And when a neurotransmitter or a drug molecule attaches to these alpha receptors, the message they tell the blood vessel is to get small, so the response is vasoconstriction. The primary receptors found on our heart muscle cells are called beta-1, and when a messenger attaches to these beta-1 receptors, the result is an increase in the rate and force of our heart's contraction. Beta-2 receptors are found in a number of places in the body, primarily in the smooth muscle of both our blood vessels and our bronchi. And when a message is sent to beta-2 receptors, it causes those smooth muscles to relax. So when a neurotransmitter from the sympathetic system attaches to it, our bronchioles get big and our blood vessels get big. The reason that this plays a role in vasoconstrictors is that some vasoconstrictors have activity at both alpha and beta receptors, while other vasoconstrictors have more activity at alpha receptors and less activity at beta receptors. So we need to think about this. If we give a vasoconstrictor that has activity at alpha and beta, when it attaches to alpha, it will cause our blood vessels in the skin and mucous membranes where we're putting our local anesthetic drug to get smaller, and that's a good thing. But it will also attach to the beta-1 receptors of our heart and increase the rate and force of the contractions of the heart in the patient that we've given it to. As you know, vasoconstrictors come in different concentrations. These concentrations are a ratio of how many milligrams there are in each milliliter of drug that is given. What you see listed here are the common dilution ratios of vasoconstrictors used in dentistry. Levonorepinephrine is used in a concentration of 1 to 20,000. This results in 5/100ths of a milligram in each milliliter that's given. Epinephrine is available in 3 different concentrations: 1 to 50,000, 1 to 100,000, and 1 to 200,000. I think what's most important for you to recognize is that at a concentration of 1 to 100,000, what you are administering is 1/100th of a milligram in each milliliter of anesthetic that you administer. It's also important to recognize that this dosage, 1 to 100,000, is twice as strong as this dosage, 1 to 200,000, and half as strong as this dosage, 1 to 50,000. That means the bigger the number, the more diluted the ratio. Epinephrine is the generic name for the trade name drug called Adrenalin. It is the most commonly used vasoconstrictor in dentistry, and as I mentioned, it's a catecholamine. What's important for you to recognize is that epinephrine, when it goes into the body, is capable of attaching to both of those alpha and beta receptors, basically on a ratio of 50-50. That means that when we administer epinephrine, it will attach to alpha receptors and cause vasoconstriction, but it will also attach to beta receptors and cause an increase in heart rate and force of contraction. It will attach to the bronchi and cause them to dilate. As I mentioned, it is available in 3 different concentrations. The one that is most commonly used is 1 to 100,000. It has a 1/100th of a milligram per milliliter, and since we administer 1.8 milliliters per cartridge, you take this number, you multiply it by the amount we give, which is 1.8 milliliters, and that means each time you deliver a cartridge of local anesthetic containing the vasoconstrictor epinephrine, you are administering 18,000ths of a milligram in that cartridge. You'll notice that this number is twice the amount and this number is half the amount. It's easiest to figure out how much you're giving if you remember this number. As I mentioned previously, epinephrine, because of its beta activity, can affect the heart. It increases the output and rate when it attaches to the beta-1 receptors on the myocardium. It also increases the likelihood of dysrhythmias because it can attach to the pacemaker cells. When we give it in small doses, we notice an increase in systolic blood pressure, but a decrease in diastolic. When it's given in much larger doses, we get an increase in both systolic and diastolic reading. As I mentioned already, its primary action on our blood vessels is that of vasoconstriction. So can we safely use epinephrine if our patient has a documented cardiovascular situation? Well, the use of epinephrine in dentistry is recommended by the American Heart Association in limited doses in well-controlled cardiovascular patients. It's important to remember a few things. First of all, if our patient is in pain, then their own body is going to release its own epinephrine. That's its endogenous epinephrine, if we don't control their pain. And they may release more epinephrine in response to pain that they feel than they would ever absorb into their bloodstream by us administering a controlled or limited amount of a local anesthetic containing epinephrine. Secondly, if our patient has poorly controlled cardiovascular disease, then elective dental treatment isn't recommended for them at all. If we remember to aspirate, inject slowly, and administer the smallest effective dose, we should be very safe using epinephrine on our patients who have well-controlled cardiovascular issues. What's important to remember is the maximum safe recommended dose of epinephrine per appointment for a cardiovascular patient is 0.04 milligrams per appointment. And as you will see later on, that translates into 2 cartridges of epinephrine at a dilution ratio of 1 to 100,000. The maximum safe dose for a healthy adult patient with no issues is 0.2 milligrams, which is many more cartridges. You should also know that tachycardia and cardiac palpitations are a common side effect in anybody. They don't have to have a cardiovascular disorder in order to feel that. This is something we expect to happen. It's very transient, and it never indicates an allergic reaction. But you will have a number of patients who tell you that they can't receive local anesthesia, and when you question them about what their allergic reaction was, they'll tell you it makes their heart race. So it's important to be able to explain to them when you administer this that they may experience an increase in their heart rate, or they may feel their heart pounding. It lasts a very brief amount of time. It's something that we see in many patients, and it does not indicate that they're allergic to the local anesthetic. There are 3 different medications under which we should not administer epinephrine when our patients are taking these medications. Those are the 3 you see listed here. Many patients take antidepressants. So if you have a patient on an antidepressant, you should look it up in a drug reference to find out whether it is pharmacologically known as a tricyclic antidepressant, because there are many newer antidepressants which do not function by that mechanism. But if the patient is taking a tricyclic and we administer epinephrine, it could cause an increase in their blood pressure, which could be dangerous to them. Again, if they're taking a beta blocker, which is used for certain cardiovascular disorders, there are beta blockers which are selective and non-selective, and we must use caution or lower doses of epinephrine or no epinephrine at all if our patient is taking a non-selective beta blocker, because they will have an increase in blood pressure which we don't want to see. The most important of these is if our patient is using cocaine. Cocaine is a very powerful central nervous system stimulant. And when the central nervous system is stimulated, it causes also an increase in the outflow or activity of the sympathetic nervous system. When that happens, the heart rate and the blood pressure both go up. So the combination of epinephrine in someone who has recently used cocaine can be a very dangerous one. It can lead to severe hypertension, it can lead to cardiac arrest, or it can lead to a cerebrovascular accident or a stroke. So if you suspect that your patient has recently used cocaine, you should not administer epinephrine. Levonorepinephrine or neocobaprine is a synthetic catecholamine which has a lot more alpha than beta activity. That means it won't have nearly the amount of activity on the heart that epinephrine does. But it's less potent, and so it has to be used at higher concentrations. When it's in a local anesthetic in dentistry, its concentration is 1 to 20,000, or that's its dilution ratio, resulting in 5/100ths of a milligram in each milliliter that's administered. It is absolutely contraindicated for use in patients who are taking tricyclic antidepressants. It was the vasoconstrictor found in Octocaine, but it's currently unavailable in the United States. It's manufactured in Europe, and because of things that have resulted from the incident on September 11th in 2001, it is not currently available for importation into the United States. So carbocaine is available at this moment only in a 3% concentration with no vasoconstrictor. The maximum safe dose for adults is 1 milligram per appointment, which translates to 11 cartridges. Norepinephrine was a vasoconstrictor that it was used actually with the drug Procaine or Novocaine. It is only 1/4 as potent as epinephrine, but you'll notice here it has a high degree of alpha activity. This means it's a very powerful vasoconstrictor. And as a result of that, when it's administered, it closes the blood vessels down too much, which leads to ischemia. There's not enough oxygen coming to the tissues that you've closed off the blood supply to, and that can lead to tissue necrosis or sloughing. Phenylephrine or neosynephrine is a drug that you may recognize as a nasal decongestant. It is a synthetic vasoconstrictor. It's a non-catecholamine, which is only about 1/20th as potent as epinephrine, so its dilution ratio is very small. It is almost exclusively active only at alpha receptors with very little activity on beta receptors in the heart. It too was used as a vasoconstrictor with Procaine and is no longer available. We should be aware that patients can experience vasoconstrictor toxicity as well as toxicity from the local anesthetic. This can be caused if we accidentally inject the drug intravascularly, and you need to know that you can do an intravascular injection even when you've been very careful about aspirating. You also can administer this drug to somebody who's a hyperresponder. That means you use a normal dose and they overrespond. You can get toxicity from a drug-drug interaction, and the most common cause of vasoconstrictor toxicity is seen when epinephrine is impregnated into retraction cords and then placed into the sulcus. So what happens to the patient? Well, they become very tense, very restless, and they start to feel very anxious and fearful. Their heart rate goes up, their blood pressure goes up, and they may experience palpitations and visibly shake or develop tremors. What can we do about it? There isn't really a whole lot we can do. Our most important thing here is to remain calm and reassure the patient. The effect of vasoconstrictor toxicity is usually very brief. The duration of action of epinephrine once it enters the bloodstream is very brief. So we need to tell the patient this is going to go away very quickly. Observe them carefully and put them in the upright position, because their blood pressure will go up, and in the upright position the force of gravity will help to lower that blood pressure. Monitor their vital signs and just keep an eye on them. So which patients may have a contraindication to using vasoconstrictors? Well, as I mentioned, if they have significant cardiovascular disease, that's an ASA category of 4, which means we probably wouldn't be treating them anyway. If they have uncontrolled or not well-treated hyperthyroidism, or poorly controlled or not well-treated diabetes, if they have a sensitivity to sulfite, if they're taking tricyclic antidepressants, or if we suspect that they are cocaine abusers and have recently used the cocaine. So when should we consider using a vasoconstrictor? Well, we have to think about how long do we need the patient numb for? Do we need to control bleeding during and after the procedure? Do we want them numb for a significant amount of time to control their pain after the procedure? And what's the medical status of that patient in terms of receiving a vasoconstrictor? Do we have to limit the amount that we give them? So here we go, local anesthetic drug calculations. How do we figure out how much we have given the patient? Well, all local anesthetics and all vasoconstrictors have what is called a maximum recommended dosage. And this MRD can be based either on the patient's weight, we can give them so many milligrams for each pound that they weigh, or it can be based on an absolute maximum. So we have to be able to compute the milligrams of drug that we give to our patients in order to avoid giving them more than this maximum recommended dosage. If you look at page 58 of your textbook on table 4.4, you will see the maximum recommended dosages of currently available local anesthetics used in dentistry. So what factors do we have to consider in determining what's the maximum safe dosage? Well, our patients will vary greatly in their weight, in their physical size, and their medical status. So we should use the smallest clinically effective dose at its lowest maximum safe dose. And when we have patients who are medically compromised, debilitated, very young or very old, then we need to decrease that dosage, because the maximum recommended dosage may be lower when patients fall into those categories. These next slides show you what the maximum recommended dosage in milligrams are for the commonly used local anesthetics in dentistry. Lidocaine has a maximum recommended dose of 2 milligrams per pound, or an absolute minimum of 300 milligrams. Mepivacaine has the same MRD. Prilocaine has an MRD of 2.7 milligrams per pound, or an absolute maximum of 400. Articaine is 3.2 milligrams per pound, or an absolute maximum of 500. Bupivacaine has a maximum of 0.6 milligrams per pound, or an absolute maximum of 90 milligrams. So how do we find out how many milligrams we're giving? Well, first we have to find the number of milligrams in each milliliter of solution. This is based on the concentration of the anesthetic. So step one is find out how many milligrams are in each milliliter. Once you've determined that, then you have to find out how many milligrams are in each cartridge. You simply take the number of milligrams in a milliliter and multiply it by 1.8. That tells you how many milligrams are in each cartridge that you're administering. Once you've found out how many milligrams are in a cartridge, you take that amount and you divide it into the maximum recommended dosage. This will tell you how many cartridges you can give before you reach the maximum recommended dose. I'm sure that some examples will help you understand this a little better. So what does concentration mean? You see here 2%. You'll remember that lidocaine is generally administered as lidocaine 2%. That means that there are 2 grams of lidocaine in every 100 milliliters of lidocaine solution. Well, we're not giving anywhere near 100 milliliters, so we have to reduce that. 2 grams is the same as saying 2,000 milligrams. They're equal. So for every 2,000 milligrams in 100 milliliters of solution, to reduce that to milliliters, you simply cross off the zeros. Take off these 2 zeros, take off those 2 zeros, and it ends up saying that a 2% solution has 20 milligrams of drug in every 1 milliliter that you give. But normally you are giving things according to a cartridge, which is 1.8 milliliters. So you take the amount that is in 1 milliliter, which is 20 milligrams, you multiply it times the amount in one cartridge, which is 1.8 milliliters, and that means that you are giving 36 milligrams of drug every time you give a cartridge of 2% solution. If the maximum recommended dose for this drug is 300 milligrams, then you take those 36 milligrams and you divide it into 300 milligrams. That tells you that you can use approximately 8.3 cartridges. So consider 8 cartridges of a 2% solution to be what would reach the maximum recommended dosage. What happens if you give more than 1 cartridge? Well, you multiply how much you give by the amount of milligrams that you find in each cartridge. For example, you give 2.5 cartridges of lidocaine 2%. You've already determined that at 2% lidocaine you are giving 36 milligrams in each cartridge. So you take that amount and you multiply it by 2.5, which is 2.5 cartridges. That tells you that you've given 90 milligrams of lidocaine if you've given 2 cartridges. What if you give less than a cartridge? Well, then you're going to divide the milligrams per cartridge for the drug that's given by the amount given. For example, you use half a cartridge of lidocaine 2%. You know that there are 36 milligrams in the cartridge. You've given only half of it, so you divide it by 2. That tells you that you gave 18 milligrams of lidocaine. We have to be careful when we are determining the maximum recommended dosage when we have a patient who may weigh a whole lot less or a whole lot more. Take a look at this example. Xylocaine has a maximum recommended dose of 2.7 milligrams per pound, but that dosage should never exceed a total of 400 milligrams. If we have a patient who weighs 100 pounds, we take their weight and we multiply it by that recommended dose of 2.7 milligrams per pound, and that tells us that for a patient who weighs 100 pounds, the maximum we should give them is 270 milligrams. If we went by the absolute maximum recommended dose, we would say, well, we can give this patient up to 400 milligrams. But if they don't weigh very much, then we're actually giving them more than they should be receiving. On the other hand, let's look at a patient who weighs 150 pounds. We take their weight, we multiply it by the maximum recommended dosage of milligrams per pound. That's 2.7, and that tells us that they should receive or could receive a maximum of 405 milligrams. But 400 milligrams is the maximum recommended dosage for this drug. So this patient should not receive more than the maximum recommended dosage. That means for any weight greater than 150 pounds, this patient can only receive 5.5 cartridges. Well, how did I get to that figure? I took the absolute maximum recommended dose and I determined how many milligrams there are in a cartridge of Xylocaine. Xylocaine comes in concentrations of 4%. 4% means that there are going to be 40 milligrams in each milliliter of solution. When you take 40 milligrams per milliliter and you multiply it by the 1.8 that's in each cartridge, it tells you there are 72 milligrams in each cartridge. You take the amount that is in each cartridge and you divide it into the absolute maximum recommended dose, and it tells you that you can give 5.5 cartridges before you have given the maximum recommended dose of 400 milligrams. If all of this is about as clear as mud, let me tell you that I have or will be posting on the Blackboard site that accompanies this course some Word documents that will take you step by step on how to calculate the dosage that you find in local anesthetic, the doses that you find in vasoconstrictors, and how to determine what is called the limiting factor. You will also find some practice problems and the answers to those practice problems so that you can work on this a little bit on your own. And as you've been informed, I will be available for 2 different live chat sessions and can answer your questions regarding this issue or any other issues that you may have. Here's a simple chart to help you remember. If you don't want to go through the hassle of trying to figure out how many milligrams there are in each cartridge, you can just go and memorize these. Most likely, this is the one that's most important for you to remember. You're most likely to be administering lidocaine, which is a 2% concentration. There are 20 milligrams in each milliliter. Multiplying it by how many milliliters there are in each cartridge tells you there's 36 milligrams in a cartridge. This would be mepivacaine at 3%. This would be Xylocaine at 4%. We also have to take into consideration the fact that our vasoconstrictor drugs have a maximum recommended dose. This maximum recommended dose is going to be based on the medical status of the patient. Remember, we limit it more if they are a documented cardiovascular patient. And it's also based on what the dilution ratio of the vasoconstrictor is. It's very important that you recognize the maximum recommended dose per appointment for epinephrine in a healthy adult is 0.2 milligrams. For levonorepinephrine, it's 1 milligram. If you have a well-controlled cardiovascular patient, that maximum recommended dose of epinephrine per appointment is decreased to 0.04 milligrams and 0.018 milligrams of levonorepinephrine. These are the maximum recommended doses for all of the vasoconstrictors that were available, although, in my opinion, it's just most important for you to key in on that maximum recommended dose for epinephrine. Perhaps for levonorepinephrine, but as I mentioned, it's not currently in use. The other 2 are not in use in the United States. So how do we calculate the dose of the vasoconstrictor? It's basically the same steps. Some people find it a little bit more confusing because of that dilution ratio. But basically, the first thing you need to find out is how many milligrams are there in each milliliter of solution that we give. Once we find out how many milligrams are in a milliliter, we multiply those milligrams by how many milliliters we've given. And then we divide the amount that's been given into the maximum recommended dose. Let's take a look at an example. When we give epinephrine in a dilution ratio of 1 to 100,000, this means that in each gram of epinephrine, each gram of epinephrine has been diluted in 100,000 milliliters of solution. 1 gram is the same as saying 1,000 milligrams. So if we look at a dilution ratio of this, it means that for every 100,000 milliliters of solution, there are 1,000 milligrams of epinephrine. Well, we don't come close to giving this amount. So again, we just take these 3 zeros, cancel them out by these 3 zeros, and that tells us in every 100 milliliters of solution, there was 1 milligram of epinephrine. But we don't come close to giving 100 milliliters either. So how much epinephrine is in 1 milliliter of solution? You simply take this 1 milligram and you divide it by these 100 milliliters, and that tells you that in each milliliter you have 1/100th of a milligram of epinephrine. Again, in each milliliter of solution you are giving 1/100th of a milligram. If you give an entire cartridge, which is 1.8 milliliters, you multiply that by the number of milligrams in each milliliter, and that tells you in each cartridge of anesthetic you are giving 18 thousandths of a milligram of epinephrine. So each time you give an entire cartridge of anesthetic, this in a dilution ratio of 1 to 100,000, you are giving 0.018 milligrams of epinephrine. How do we calculate the maximum recommended dose of epinephrine? Well, we know that in a healthy patient, we have to limit it to that amount. In a cardiovascular patient, we have to limit it to this amount. And we know that we are giving 0.018 milligrams in each cartridge. So we take the maximum recommended dose, we divide it by how much is in each cartridge, and we find out that for a healthy patient we could give 11 cartridges before we reach the MRD. But in a cardiovascular patient, when we use this dilution ratio, we can only administer 2 cartridges per appointment. Local anesthetics and vasoconstrictors will reach what we call a limiting factor. Both the anesthetic and the vasoconstrictor have a maximum recommended dosage. One of these, either the vasoconstrictor or the anesthetic, will reach the maximum recommended dose before the other, and this is what is called the limiting factor. Let's take a look at an example. The MRD for 2% lidocaine is 8.3 cartridges based on its absolute maximum recommended dose. The MRD in a healthy patient, when we use epinephrine in a dilution of 1 to 100,000, is 11 cartridges. So in this example, the lidocaine itself becomes the limiting factor. We reach the maximum recommended dose of the lidocaine before we reach the maximum recommended dose of the epinephrine. This is a chart that shows you what the maximum safe dose or maximum recommended doses per appointment are when you use the various dilutions of epinephrine, 1 to 50,000, 1 to 200,000, 1 to 200,000, or if you were to use the vasoconstrictor levonorepinephrine. In a healthy patient, as I just mentioned, this dilution ratio is 11 cartridges. You'll notice that when it's twice as concentrated, it's half that amount. When it's half as concentrated, it's twice that amount. And the same is true for cardiovascular patients. Local anesthetics can produce general adverse effects because, as I've mentioned, they do get into the bloodstream. They get into the bloodstream because of vasodilation. You'll remember that local anesthetics by themselves cause this vasodilation, so we have to be particularly aware of this fact if we ever use a local anesthetic that does not contain a vasoconstrictor, such as 3% mepivacaine. Other factors that contribute to toxicity is the concentration of the anesthetic that we use. Obviously, if we're using a more concentrated drug like 4% prilocaine, there's a greater chance of toxicity. The way in which the drug is given, if we accidentally inject this intravenously, as I mentioned before, even when we aspirate carefully, sometimes there is a risk of accidentally not knowing that we are in a blood vessel. The other thing that I want to call to mind here is that you can produce a toxic amount of local anesthetic in the bloodstream by overusing a highly concentrated form of a topical local anesthetic. Even though the route of administration is topical, we're putting this drug in an area of the body where there's a fair amount of vasculature. And topical anesthetics do not contain vasoconstrictors. They simply contain the local anesthetic. So we apply a lot of topical. The topical anesthetic produces vasodilation in an area that's already vascular, and then that topical anesthetic is quickly absorbed into the bloodstream. How quickly we administer the anesthetic also determines the ability of the drug to get into the bloodstream too quickly. So slow down your rate of injection. Plus it makes your patient feel a whole lot more comfortable. Also, always take into consideration the patient's weight. As I mentioned, small adults, underweight adults, children, or patients with physical status problems like liver and kidney dysfunction. We have to be very careful when we administer anesthetics to these patients. They are more likely to suffer toxicity because their bodies are not going to metabolize these drugs at the same rate. The adverse effect that concerns us most with local anesthetic toxicity is that which can occur in the central nervous system. Usually this means that we gave too much of a dose in relationship to the patient's age, weight, or medical status, or there was an accidental intravenous injection. It's important for you to know that the pharmacological action of local anesthetics when they enter the bloodstream and get up into the brain is to cause depression of the central nervous system. But you'll see that the next statement says the primary clinical manifestation of this CNS depression is a generalized tonic-clonic seizure, and that the initial clinical signs and symptoms are usually excitatory in nature. That's why we see a seizure. Except if we have used the drug lidocaine in a toxic amount, in which case these central nervous system signs and symptoms are more likely to proceed right to those of sedation. So what are the signs and symptoms that we see when the CNS is subject to excitatory input? Well, the initial signs and symptoms would be the patient may become apprehensive, they may appear disoriented, and then suffer a convulsion. Initially, there'll be an increase in heart rate and blood pressure, which will be followed by a decrease in blood pressure and heart rate. So if we suspect that there has been a toxic amount of anesthetic absorbed into the bloodstream, we have to make sure that we are monitoring these patients' vital signs. You should also recognize that if central nervous system depression becomes too overwhelming, the patient can go into cardiac arrest. If the patient suffers from a tonic-clonic seizure, our best course of action is to await the cessation of that seizure, because usually this is a self-limiting episode. As the drug gets metabolized, the seizure will stop. If the seizure becomes very prolonged, we certainly need to intervene with alerting the medical emergency system, calling 911, and the drug of choice to stop prolonged seizures is the administration of injectable Valium, which is not something that we would do, but you should probably know that that is how a prolonged seizure would be treated. Let's take just a little closer look at why we're giving a drug that is called a central nervous system depressant, but the sign that we see when we get an overdose of this drug results in central nervous system stimulation or excitation. Output in our brain is maintained by a balance between chemicals that excite our nerves and chemicals which slow down impulse transmission in our nerves. These are called excitatory transmitters and inhibitory transmitters, and pretty much the brain is kept in balance. Excitatory or facilitatory impulses tell the brain to send messages, and inhibitory neurons tell the brain to stop sending messages. So they kind of control each other. If someone suffers from local anesthetic toxicity, what's happening is we are disrupting this balance. It can lead to CNS depression or CNS stimulation. At low or moderate levels, the local anesthetics are basically blocking some of the inhibitory pathways in certain areas of the brain. And this kind of tips the balance in favor of those excitatory impulses. In other words, the excitatory impulses don't have any inhibitory impulse to kind of counteract their message. And that's why we see the manifestation of a seizure, which we normally associate with too much central nervous system stimulation. As I mentioned, at these higher blood levels, the inhibitory function can become entirely depressed and we get pure excitatory input without any inhibition. That's what produces these seizures. Eventually, the depression can lead to both inhibitory and excitatory functions being depressed, and this could result in the patient's death. It might be comforting for you to know that as far as I know, there has been no reported death due to injection of local anesthetic toxicity that's been administered by a dental hygienist. This little schematic shows you that when we entirely block inhibitory impulses, we get pure facilitatory or excitatory impulses, but by blocking both, this is what results in no input going to the brain and can result in the patient's death. Other adverse effects could be local reactions. We generally could see tissue injury or irritation. This has to do more with our technique than anything else, and Deb will be discussing this in her presentation on local and systemic reactions a little bit further, as well as the condition known as hematoma. I've pretty much covered the adverse effect of allergic reactions. I would caution you to make sure that when your patient tells you they have an allergy to local anesthetics, question them carefully and make sure that what they're telling you are true signs and symptoms of an allergic reaction. Many people will report signs and symptoms that have nothing to do with an allergic reaction. Be aware that some people are allergic to methylparaben, and although that's not in our injectable anesthetic, it is in some of our topical anesthetics. Sulfites are the antioxidant that we have to be concerned about if we are using a vasoconstrictor. And if a patient has a documented allergy to any ester-based anesthetic, they are immediately cross-allergic to any other ester-based anesthetic, even though they may never have been exposed to it. Syncope is the most common adverse reaction reported. It's mostly due to anxiety or fear of having the injection. We don't see it nearly as often now that we work with our patients in the supine position to begin with. Keep in mind that when we administer local anesthetics, it not only affects the neurons in the area we're trying to work on, but once it enters the bloodstream, it can have an effect on cardiovascular neurons, particularly those that are involved in heart conduction. So we want to avoid giving large doses to patients because it can interfere with the normal rhythm of the heart. If local anesthetics have to be administered during pregnancy or when a woman is nursing, then lidocaine is the drug of choice and should be given in the smallest effective dose. Our last topic is that of topical anesthetics. And I have heard from any number of people who have taken the computer nerve examination for local anesthesia that there are a fair amount of questions on topical anesthetics, so this is important information for you to review. Local anesthetics, when we apply them topically, are used to control sensations from sensory nerve endings that we find in our soft tissues. It's important that you understand that most of the topical anesthetics that we use are not able to penetrate intact skin, but they can penetrate mucous membranes of our mouth for a degree of about 2 to 3 millimeters, and they can penetrate any area where there is abraded tissue. But if we apply them to abraded tissue, that's going to increase their systemic absorption. In order for them to have any effect at all, they have to be applied for the correct length of time. And the correct length of time for most topical anesthetics is 1 minute for its onset of action. So when asked, how long do you have to apply the topical anesthetic for, the answer is 1 minute. Some cautions to be aware of, which I mentioned briefly in the past. Although we're applying them topically, they do get absorbed systemically, especially when we put them on abraded tissue or in an area of a mucous membrane which is highly vascular. Also, the concentrations that we are using are higher than those of an injectable anesthetic. So that means the milligrams in each amount that we deliver is higher than each milligram in our injectable anesthetic. The other thing to remember is topical anesthetics do not contain vasoconstrictors, but the drug itself produces vasodilation. So this itself contributes to the amount of drug that can be absorbed into the bloodstream. We can produce the same blood levels by over-administering a topical anesthetic as when we inject a cartridge accidentally intravenously. So we have to make sure that we use these things cautiously, limit the amount we use, and do good tissue isolation. Only put this drug where you need it and only in the amount that you need it. Topical anesthetics come in a number of different delivery systems. They're available as sprays. The disadvantage to a spray is that the area that you put it on is very hard to confine, and the patient can inhale it. For example, you may decide to use a spray on the hard palate because your patient is gagging when you try to take radiographs. But because you can't confine it to the hard palate, some of that is going to go back on the soft palate. The patient can inhale it. When the soft palate becomes anesthetized, the patient won't be able to feel themselves swallow. They'll still be able to contract the muscles that allow them to swallow, but the brain won't sense it, and therefore the brain won't believe that it's swallowing. So the patient may have a panic attack, and this can be difficult. Therefore, sprays are now dispensed with a metered dose so that we don't over-dispense them. These same issues come up if we apply a topical anesthetic with a delivery system that we paint on, that is, a liquid anesthetic. Again, it can cause the throat to feel numb, or it can cause the patient to cough, and it's difficult to control the amount that we apply. Your best bet is to use the topical anesthetic in a gel or ointment delivery system. This is the most common way to administer topical local anesthetics. The last delivery system is a transoral patch, and during the clinical portion of the program, you will be introduced to the DentaPatch, which is lidocaine, and shown how to use that. Benzocaine is a very commonly used topical anesthetic in many dental practices. It's not one of my favorite topical anesthetics because it does produce some local tissue reactions. You should recognize that benzocaine is an ester-based anesthetic. Therefore, it is capable of causing allergic reactions, but most of these tend to be local allergic reactions, and even in patients that do not have a documented allergy to an ester, benzocaine often causes tissue irritation. After we put it on, we see a lot of tissue sloughing, and the patient may be sore in the area of our injection. It has nothing to do with our injection technique. It is caused by the irritation resulting from benzocaine usage prior to actually administering the topical anesthetic. Benzocaine is found in many over-the-counter products available in pharmacies, like first aid creams, burn creams, etc. In the dental office, you might commonly see this as the topical anesthetic gingicaine, Ceticaine, or Hurricane. As I mentioned earlier, tetracaine is a very potent ester which is used only as a topical anesthetic. I haven't seen this in too many dental offices. It has a fairly slow onset, so that's why it's not used. But you should remember it's an ester, and it's very potent. Its maximum dosage per appointment is 20 milligrams. Lidocaine is by far the most popular topical anesthetic used in dentistry. It comes as a gel, an ointment, a liquid, or a metered dose spray, and it's available in two concentrations, a lidocaine base of 5% or lidocaine HCl 2%, which gives us better tissue penetration but results in more systemic absorption. Its maximum recommended dose is 200 milligrams. That's a fair amount of topical anesthetic applied at one time. There also is the DentaPatch, as I mentioned, which is lidocaine that's impregnated into a transoral delivery system. Each patch, when you put on an entire patch, is delivering 46.1 milligrams of anesthetic to the area. Its most common side effect as a result of its application is a slight reddening of tissues at the site where we've applied it. Cocaine, although most of us tend to think of this as an illegal street drug, is used by the medical profession for a very effective topical application. Because of its potential for abuse, it is a well-controlled Schedule II drug, but it's available in a liquid form, is used frequently, as I said, in medicine. It has a very good duration, a rapid onset, and it does produce a lot of very good topical anesthesia. We don't use it in dentistry. diclonone or diclone is chemically different than the other agents that are available. Its potency is equal to that of cocaine, but like tetracaine, it has a very slow onset and therefore was problematic in using it in dentistry. However, once you put it on and you get effect, its duration can last up to an hour. It recently became unavailable for use in the United States. Some of you may have encountered a cream being used in your office called EMLA. EMLA stands for eutectic mixture of two different local anesthetics. It's a cream mixture of 50% lidocaine and 50% prilocaine. It actually was developed by the medical profession because it does provide surface anesthesia when we have intact skin. If you remember, I said topical anesthetics are not absorbed by intact skin. But they discovered that if they mixed these two anesthetics together and put it in this delivery system, and you applied it to intact skin and put a covering or a dressing over it, you did get good absorption. It has a rather long onset of action, but once it has its onset of action, it has a much longer duration of anesthesia than when you just use pure lidocaine. It does have the same contraindications as that of prilocaine, so you need to be aware of that if you use this particular topical anesthetic. There has recently been developed this same eutectic mixture of local anesthetics in a different delivery system that has the trade name of Oraquix. It's the same formulation, but it was developed in individual dosages that are loaded into a patient's sulcus using a small cannula, the same way that we deliver local tissue irrigation, say with Paradex. It has a shorter onset of action and a shorter duration. I've never used it myself, but I understand from practitioners who have that it is very good for getting isolated areas of anesthesia in sulcuses when you don't want to or don't need to give or have a very broad area of anesthesia. So that concludes our presentation on pharmacology. As I mentioned before, there will be a few different things up on the Blackboard site. You will be able to view and download a handout that I've developed on how to calculate the dosage of local anesthetic drug and vasoconstrictor drug, and some practice problems and their solutions. And also, again, I will be available for a live chat. The hours of that live chat, you can ask me questions. I'll try my best to type back the answers. Those times and dates will be posted on the Blackboard site, and I look forward to meeting all of you at the clinical portion of this program.